So my ask from Bert was to talk about an update on Dichoptic treatment. And of course, the good news is if you were at the opening session, you're nearly up to speed. First off, there is off-label use of falling blocks, dig rush, and movie viewing binocular treatments. I did serve as a medical monitor for Luminopia in their pivotal trial, and salary support from the National Institute, the American Academy of Ophthalmology, but nothing from NovaSight. So my objective is to review recent digital treatment results for amblyopia, except for CureSight's pivotal trial, which will be reviewed by Tamara. So the interest is clear. Look at this room, although I was told the rain outside may make this room more favorable. We've been talking about binocular stimulation, and the media talks about it, our parents talk about it, and we've talked about it at a number of meetings. And there have been modest improvements seen in uncontrolled studies for nearly 10 years. These treatments, though, are generally not available outside of the research setting, but now we have 2 approved treatments in the United States, and hence maybe that's the reason we're here. Now, binocular activities vary between all of the studies, all of the approaches. There are differences in them, so we can't think of one binocular treatment necessarily as synonymous with any other binocular treatment. But they all in some way reduce or rebalance contrast to the fellow eye with an attempt to overcome suppression, or they have moving masking of the fellow eye, which may or may not be considered true binocular therapy in the traditional sense. And then the content can be passively viewed, or there can be active engagement of the viewer with that content. And we don't know which of those approaches will actually be better at the end of the day. Perhaps we'll know in a few years. And of course, the content may be web-based, movies, Dichoptic games, first-person action games. This is an evolving field. In terms of recent clinical trials, PD did conduct ATS-18 with falling blocks. You may think of it as Tetris. We had 2 age cohorts, the younger children and the older children, with a wide range of visual acuity resulting from strabismus, anisometropia, or both, eligible 16 weeks of treatment with a randomization to 1 hour a day of the game or patching 2 hours per day, high contrast images to the amblyopic eye, and reduced contrast to the fellow eye. And the findings were published in 2 different papers. In the first group, the adjusted difference favored patching. And in the older group, the adjusted difference also favored patching. But note the compliance in the older group. 13% completed up to more than 75% of the scheduled time. It was a pretty boring game at the end of the day. You can only do Tetris so much. But because it's good to have a repeat, the Bravo trial used also the falling block design, 7 years of age or older, 115 patients, 36% compliance. They were just slightly better, and no difference compared with placebo. So this wasn't the solution. The next to enter this array, or this tourney of binocular therapy, might be Dig Rush, which is a first-person action game. The child had to see the blue targets and the minors in red and be able to interact with those to win in that game. We did 2 trials here, an older cohort, a little bit younger older cohort, this time 7 to less than 13, and the younger cohort 3 to 7. Same wide range of amblyopia, visible or eligible, but the child had to be able to see both targets. So the results for the older group, after 4 weeks, the mean vision improved from baseline by 1.3 letters, but glasses alone did a little bit better. So not the solution for the older age group, and no difference was seen when we had continued the treatment for 8 weeks of treatment. Stereo acuity, which has come up in the open session on Thursday and we'll get to in the movies, but we did not see any change in stereo. in the DIG-RUSH study. The 3 to 6 years of group, which took longer to recruit and hence was published only last year, has a little bit different story, but there's a kernel of something good is going on. So after 4 weeks of therapy, the mean amblyopic vision improved 1.1 logMAR lines with binocular treatment, 0.6 logMAR lines with continued spectacles alone, with an adjusted difference that was significant at 0.5 lines. So that sounds great. After 8 weeks, and this became a fight, a discussion, and more discussion, what to do now? So you continued the treatment and had 1.3 lines of improvement with binocular treatment and 1 line with spectacles alone. Now the difference, although still there, favoring binocular treatment compared to spectacles, was no longer statistically significant. But DIG-RUSH did get more children involved. Now 47% completed 75% of the prescribed treatment, but that did fall off a bit more at 8 weeks. So compliance with the dose that we thought might help was still not adequate. Eileen Birch and Kelly and others have talked about movies, and this is certainly another exciting era. We don't have a large clinical trial here, but just as you saw in their presentation on Thursday, and again with this study, of just a short period of treatment, the mean amblyopic eye visual acuity and mean stereo acuity in the publication both had improved with movie viewing with the masking that you see going on there. So another kernel here that there is some benefit. And then, of course, the Luminopia project really changed the story with their publication. So a lightweight virtual reality headset, modifying streaming video in real time. Contrast to the fellow eye is 15% of that in the amblyopic eye, and there's some complementary masking going on in the images that you see. The pivotal trial had a 1-to-1 randomization of treatment to control. The control treatment here, again, is full-time glasses. That's not compared to patching. That study may or may not ever be done in the future. The active treatment group, 1 hour, 6 days per week with glasses, with a 12-week treatment primary endpoint. So longer than the DIG-RUSH, shorter than the falling blocks game. And the data, the final data, if you will, the results are the primary endpoint in one slide. 88 of 117 participants had in-window 12-week visit. At 12 weeks, the amblyopic eye best corrected vision improved 1.8 lines in the treatment group, 0.8 lines in the control group, with a statistically significant difference. And interestingly, that difference was seen at 4 weeks, 8 weeks, and 12 weeks. So there is an early onset of a benefit, and it continues throughout, perhaps linear, perhaps. I don't see it becoming asymptotic yet in these data. We need the next PDIG trial, by the way, that's going to try and carry these devices out for a half a year. So going forward, we still have a pivotal trial to talk about, but we have a pivotal trial that led to an FDA approval that led to the next problem in our space. There will be medical coverage hurdles in spite of what all of the companies tell you. In February, meaning a month ago now, 2 months ago, Elevance, which is the health office now for Blue Cross Blue Shield, is currently evaluating the topic, and their preliminary plan is a non-coverage decision. That may get changed. Everybody has written to them. We'll see how that goes. Incidentally, that's what happens with every new technology going in the commercial space. It always starts as non-coverage. Second, if you're getting paid after you launch these things, that doesn't necessarily stop a company from recoupment. Now, the recoupment's not actually going to come from the doctor getting paid, of course. It's from the patient. And payers will keep citing, and they've already done that. They've taken the results that we in PDIG did and have cited those as non-significant. So if you have the good fortune to know a medical director, make sure you explain to them that those were earlier technologies. Yes, it's the same approach, but it's an earlier technology, and the results should not be viewed to offset the newer technologies with the newer approaches that seem to be working. And it will be an ongoing battle. Thanks very much for your attention.